Hemorrhagica. It is a specialized form of anovulatory AUB seen in women between 40 and 45 years age. The women develop continuous painless vaginal bleeding, sometimes starting at the onset of menses or preceded by 6 to 8 weeks of amenorrhea. Occasionally, the woman reveals a history of menorrhagia before this. Uterus is slightly bulky. Pathology: a mild degree of myohyperplasia with the uterine wall measuring up to 25 mm and a uniformly enlarged uterus is seen in metropathia hemorrhagica. The endometrium is thick, polypoidal. Thin, slender polyps are projected into the uterine cavity. The endometrium shows characteristics of cystic granular hyperplasia. The Swiss cheese pattern is the another name given to describe this endometrium. Second feature is the absence of secretory endometrium with the absence of corkscrew glands. Areas of necrosis are seen during menstruation, can be seen in the superficial surface. One or both ovaries may contain a cyst not larger than 5 cm, but corpus luteum is absent. Investigation: history of the onset, duration, amount of bleeding should be noted. Antecedent causes such as IUCD, pills, pregnancy, abortion, drug therapy are also pertinent. General examination with special reference to anemia, thyroid function, blood count, coagulation profile is carried out. Pelvic examination is done. Ultrasound to study pelvic organs to rule out pelvic organic disease. Endometrial study by curettage, uterine aspiration, and hysteroscopic biopsy is mandatory in premenopausal women and necessary in few younger women suspected to have endometrial tuberculosis. Doppler ultrasound to study the endometrial vascularity may help in the diagnosis. Hysterosalpingography, saline salpingography may be employed if hysteroscopic facilities are not available. Investigations are blood test, complete blood count, coagulation profile, structural abnormalities such as ultrasound, MRI as needed, hysteroscopy. Histology: dilatation and curettage, hysteroscopic endometrial biopsy, endometrial aspiration biopsy. Treatment of AUB: treat the cause. Menorrhagia without any organic or general disease should be treated as follows. Anemia should be treated simultaneously. The first line treatment is medical therapy. If that fails, DNC may be helpful, mainly for diagnostic purpose, but a few women may benefit from it therapeutically. If hormone treatments causes side effects, many now prefer to insert a Mirena IUCD. Failing this, decision has to be taken regarding a conservative surgery or hysterectomy. Conservative treatment: hormone therapy. Estrogen alone is not recommended because of the risk of endometrial and breast cancer. OC pills are effective in select women and not safe after 35 years of age in smokers and obese women. Progestogens are the main hormones used in AUB. Progesterone induces estradiol 17 beta dehydrogenase, which converts estradiol to weak estrone, which in turn suppresses E2 receptors, DNA synthesis, and has antimitotic activity. Thus, progestogen causes endometrial atrophy. A high initial dose of 10 to 30 mg a day should arrest the bleeding in 24 to 48 hours, after which 5 mg daily dose is given for 20 days. Withdrawal bleeding occurs 2 to 5 days after stopping the drug. A normal blood loss is expected. A further course of 5 mg daily for 20 days is started on the second or third day of the period, cyclically, especially for 3 to 6 months, given at night to reduce side effects. Dydrogesterone 10 mg does not suppress ovulation in women who desire pregnancy, and it does not influence lipoprotein. Progestogens used commonly are norethistérone, dihydrogesterone, DMPA, or newer progestin. Gestrinone, a derivative of 19-nortestosterone, is effective in an oral dose 2.5 mg twice weekly or 5 mg vaginal tablet thrice weekly for 6 months. Instead of a 3-week cyclical therapy, giving progestogen only in the luteal phase is not effective. 3-month Depo-Provera is now recommended to reduce the number of menstruation in a year. Instead of cyclical administration of progestogen, continuous oral progestogen daily for 3 months with a break of 1 week reduces the number of menstrual cycles to 4 in a year, which many women welcome. Fibroplant implant releasing 14 mcg daily of levonorgestrel is under trial. Danazol has a limited role when OCPs and progestogens are not suited to the woman. It has Androgenic side effects. Danazol 200 mg daily for 3 to 4 cycles is recommended. Clomiphene is advocated if pregnancy is desired. Ethamsulate reduces capillary fragility 500 mg 4 times a day from 5 days before the anticipated period up to 10 days reduces menorrhagia by 50% in ovulatory cycles. NSAIDs taken during menstruation for 4 to 5 days control menorrhagia by 70% in ovulatory cycles. Post IUCD and post sterilization menorrhagia. Medical therapy. Combined OC pills. Dosage 20 to 30 microgram ethinyl estradiol plus progestogen monthly for 3 months. The side effects are nausea, headache, hypertension, hyperglycemia, thrombosis, liver and gallbladder disease, and breast cancer. Progestogens 5 to 10 mg tablet 10 to 30 mg daily for 3 weeks cyclically, continued for 3 months or 3 monthly injections or as an implant. Weight gain, depression, headache, acne, abnormal lipid profile, and breast tumors are the side effects. Gestrinone, danazole 2.5 mg twice weekly, danazole 100 to 200 mg daily. The side effects are acne, hirsutism, weight gain, reduced high density lipoprotein, cholesterol. GnRH analogs 4 weekly injection. They may cause menopausal symptoms, osteoporosis, loss of libido. Tranexamic acid 1 gram given 6 hourly. Nausea, vomiting, diarrhea, headache, visual disturbances, intracranial thrombosis. NSAIDs mefenamic acid 500 mg TID. Nausea, vomiting, dyspepsia, gastric ulcer, diarrhea, thrombocytopenia. Ethamsulate 500 mg 4 times daily. It may cause nausea, headache, and rash. Mirena 52 mg levonorgestrel, less than those of oral progestogen because its action is local, resulting in endometrial suppression. However, it takes 2 to 3 months to reduce menorrhagia and the effect lasts for 5 years. Ormeloxifene 60 mg twice weekly. Antifibrinolytic agents like tranexamic acid 1 to 2 gram 4 times a day for 6 to 7 days during menstruation is effective in 50% of the cases. GnRH is employed if the above methods fail. Depot injection 3.6 mg given monthly for 4 to 6 months or 6.6 mg implant is nearly 100% successful. A longer duration of treatment with its anti-estrogenic action cause menopausal symptoms and osteoporosis. This can be counteracted by add-back therapy by giving 5 to 10 mg norethestérone or tibolone, and this allows longer administration of GnRH. GnRH takes 4 weeks to act and is therefore not effective in acute episode of bleeding. SERM, selective estrogen receptor modulator. A new drug, ormeloxifene, non-hormonal centrochroman, 60 mg twice weekly for 12 weeks to 6 months and thereafter weekly is 50% effective. It does not cause breast or uterine cancer because of its anti-estrogenic effect. When estrogen is not contraindicated and a woman needs contraception, a new drug, Seasonale, combined estrogen and progesterone, is used daily for 84 days with a gap of 6 days in a 3-monthly treatment. Menstruation occurs during the tablet-free period. It is welcomed by women because of infrequent periods. Mirena. To avoid side effects of hormonal therapy, Mirena IUCD is now employed to control the menorrhagia. It directly suppresses the endometrium with minimal side effects. It has no action on ovaries. Therefore, E2 and progesterone levels remain normal. It reduces blood loss by 70 to 90% in 3 months and acts as contraceptive for those who do not desire pregnancy. Mirena can be retained for 5 years. However, it may cause irregular bleeding during the first 3 months and the woman is advised to persevere retaining Mirena and not to get it removed on this account. About 25% become amenorrheic at the end of 1 year. A quick return of fertility is noted following its removal. About 80% conceive by 12 months. Mirena is also useful in women with menorrhagia, dysmenorrhea associated with uterine fibroid and adenomyosis. Disadvantages of Mirena. It is slightly difficult to insert, takes 3 months before it becomes effective, Amenorrhea occurs in 20 to 25, which is not desirable in younger women. Ectopic pregnancy rate is reported in 0.2 per 100 women. Hysterectomy is required in 25% by the end of 3 years because of recurrence of menorrhagia. Minimally invasive surgery. Dilatation and curettage and endometrial study are required if genital tuberculosis or endometrial cancer is suspected or the medical therapy fails. Though mainly performed by a diagnostic purpose, 30 to 40% are relieved of menorrhagia at least for a short period of time. Ablative techniques. The idea of endometrial aberration arose from oligomenorrhea occurring in Asherman syndrome due to synechium. These procedures are safe, effective with lesser morbidity than hysterectomy, as well as cost effective with quicker recovery. Hysterectomy is avoided in many cases. The endometrium is destroyed up to the basal layer. Fertility is not possible following ablative therapy. Therefore, these procedures are mainly suitable for women who wish to preserve the uterus, avoid hysterectomy, but are not interested in pregnancy. The method should destroy 2 to 3 mm of myometrium if recurrence of menorrhagia has to be avoided. The first generation procedures are hysteroscopic endometrial ablation by resectoscope, loop, roller ball coagulation, and laser. Second generation include radiofrequency induced thermal ablation, cavatum balloon therapy, microwave endometrial ablation, laser therapy. Minimal surgical methods of treating menorrhagia. Ablative technique. First generation and second generation. Uterine tamponade, bilateral uterine artery embolization are second generation techniques. Hysteroscopic endometrial ablation. These procedures should be performed after the menstrual period or the endometrium is thinned out by giving progestogens, danazol or GnRH for 4 to 6 weeks before the procedure. Uterine size should be greater than 12 weeks. Uterine fibroid are the contraindications. Scarred uterus, young woman desirous of pregnancy, adenomyosis, genital infection, uterine cancer are the other contraindications. TCRE under general anesthesia using hysteroscope destroys 4 to 5 mm endometrium and forms uterine synechium. Complications are anesthetic complication, fluid imbalance with fluid overload, uterine, bowel and bladder injury, embolism, infection, hemorrhage. Menorrhagia occurs in 25% cases by the end of 3 years and needs hysterectomy or repeat TCR. Radiofrequency induced thermal endometrial ablation. It is a blind procedure using radiofrequency electromagnetic thermal energy which destroys the endometrium at 66 degrees centigrade. A 0.6 mm metallic probe is inserted transcervically under general anesthesia and rotated over 360 degrees for 20 minutes. About 85% get cured, 30% develop amenorrhea by the end of 1 year. It is cheaper compared to TCRE, does not require hysteroscope, and complication of distending media are avoided. Advantages of RITIA. Less skill is required to perform the procedure, less risk with the procedure. Cavatum balloon therapy. Under local anesthesia, the catheter is inserted transcervically into the uterine cavity and the balloon is distended with 15 to 30 ml of sterile solution such as 5% glucose, 1.5% glycerin. The heating element in the balloon raises the temperature to 87 degrees centigrade and this temperature is maintained for 8 minutes over a pressure of 160 to 180 mmHg to exert a tamponade effect. The catheter has inherent safety design related to time, pressure and temperature and it gets automatically deactivated to avoid complications.